My name is Shyam Kolvekar. I'm one of the cardiothoracic surgeon at Bath's Heart Center on University College London. I was asked to talk about diagnosis of chest wall deformity, especially in view of excavatum and carinatum. Most of these diagnoses are very obvious because a patient come with you that either that person has a pigeon chest or has a dent in a chest or called funnel chest. And it's very obvious. Even a simple picture of it in different views can give you diagnosis. The simplest test we do initially is a chest x-ray, not just a plain chest x-ray, but if you do a lateral view, can give you the depression or protrusion of a chest wall. And there are a lot of indexes people have developed. The important thing about the indexes are to have a common language. At present, something which is depressed, severe or mild and moderate, it's a personal thing, and it's always a subjective, not objective. So radiologist, chest physician, surgeons came together to formulate different indexes, for some to give their names to it, or some of them to make it simpler. So much so, one of the most popular index is called Heller index. Heller is a radiologist who went on a CT scan and measured the dimensions of the depression of a sternum in view of a spine, the maximum horizontal diameter and the vertical depression, and then called a ratio. Normal Heller index is up to 2 in most of the people. If it's more than 3.5, it was considered very severe. Similarly, there are a lot of index came because it's not symmetrical all the time. You have asymmetric index, you have a symmetry index, then you go from a rib cartilage, then you go for how much displacement of organ, i.e. the heart, or how far it's displaced. Depending on different complexity of a severity, people came with indexes. So diagnosis, once you've done original diagnosis, you do go for different investigations. The commonest one we take on is a CT scan, because CT scan with a 3D skeletal correction is one of the still a gold standard test, because it tells you the position of the ribs, there are fusion of ribs, the cartilage margins, and also tells you the status of cartilage, because it decides what operation you can decide, and also it's important for patient also to explain. The next is, if there are younger patients, sometimes it's important to MRI scan, because MRI scan can also give a similar cross-sectional investigations. But besides those diagnostic tests, you need some other tests to do the functional evaluation. You can do the CPEX, where you do exercise and see whether there is a problem with exercise tolerance with people with severe deformity, or you can do a test with lung functions, full lung function, see if it's depressed, especially lung capacities are low in some of the severe deformities. Then you do echocardiogram, because there is a correlation between Pectus excavatum, Marfan's and other heart there are some anecdotal cases of leaky valves or mitral or tricuspid regurg, and that's the reason we need to do that. These are the simpler tests you must do initially to go ahead with the surgery. But no test is complete other than clinical examination. It's psychological evaluation. We saw a physical part of a problem. It's very obvious. If you look at my diagram here, this is if you call Pectus excavate, and there is a defect. And if you think as a simple as a quadrangle, and if you have 4 triangles, and then if you decide what is missing, so obviously if you correct this triangle up to the level, almost like a quadrangle, this part which is shaded triangle will increase that area into your chest cavity. It's obvious that it will increase your lung capacity. If something is displaced and brought back, it will also improve heart function. There are articles showing that there are stroke volume is increased after corrections, and I just thought it's the simplest thing to show to anyone that if you have a chest like this and if you make it just like that, the improvement is that much, and it's very obvious. But besides all physical and physiological part of it, most importantly also psychological, because people who are suffered, especially in Britain, initially people ignored them because they thought there's nothing we can do, go, you'll be fine. Majority of time people will be fine in a way, physical sense of it. But they have a lot of other issues, because can you imagine a boy in the school and the PE time taking out a t-shirt in a common bath, my God, they will be harassed. And children are quite cruel, and that's why these people don't take out their shirts in a beach or a school, and then that make them introvert, and it prevents the development. I personally feel that psychological need is as important as physical need of this patient. So I think in investigation we must have psychological assessment from a qualified psychologist to see how much it's affecting the confidence of the person, how much it affects. There is something called body dysmorphia. That means people feel that the rest of their problem of the body is linked to a deformity. And if you collect the deformity, all the problem will be solved. I know it's not that right, but sometimes that can affect severely. And these teenagers who suffer from it can go into depression, and it will knock their confidence, and also in the school they may not do well. Of course, sport is a very big thing, and they may not voluntarily ever take part in a sport because of exposing their chest. So my feeling is diagnosis of a pectus deformity is essential, and it's far more essential in excavatum because its depression effect in the thoracic cavity definitely leads to less lung volume and also displaces the heart, leading to reduction of stroke volume and exercise tolerance. Its carinatum and other deformities, it may not be that bad, but these deformities are associated with some malformation inside the chest. Marfans could have a problem with your aorta and also with the heart. If you have some issues with the underlying lungs, and they are also need to be dealt with. So overall, starting with a simple dent in the chest, it can involve a lot of subspecialties joined together form. So my personal feeling is for chest wall, diagnosis for chest wall deformities, we need a multifactorial effect. Besides doing all the tests and investigation, we should have a joint MDT, discussion of patient, and we must always involve patient in a discussion because it's not all that simple of any other things we do. I think to find the indexes, recently we published a book on chest wall deformity, which is republished on 12th of January, which a lot of reputable surgeons and anesthetists and physicians contributed into it. And there's a chapter by Martis Ferro about indexes for pectus deformity, and some of them are quite interesting. Especially, there are several of those indexes and investigations, and these are very important if you want to detail study on that. And this is the best example how you can measure from outside other than a CT scan, but CT scan is one of the important investigations. But I think there's a full chapter on that, and I just thought if the readers want to go with the more details, they can refer to one of our books. Thank you.